Good afternoon, everyone. It's a real honor to introduce Dr. Ken Lee and the miraculous work he is doing. And the title of this session is Sublicate, the First 75. Just some last minute housekeeping directions is that questions should be submitted via the chat function, and these will be addressed in the last 15 to 30 minutes of the session today. Please also be aware that there will be an evaluation link that will pop up at the top of your screen near the end of the session, and please complete it. Dr. Lee is the medical director at the London Rapid Access Addiction Medicine Clinic. The RAAM Clinic was started in 2014 as part of the Arctic Metafood Project. The project has developed a care path for patients with addictions, both opiates and alcohol, to redirect them from the ER to the RAAM Clinic. Dr. Lee's general medical practice is located within the Canadian Mental Health Association, providing medical and psychiatric care to persons diagnosed with serious mental illness. Other current work includes Veteran Affairs Canada, Operational Stress Injuries Clinic, treating Canadian Forces veterans suffering from PTSD, surgical assistant at London Health Sciences Centre, College of Physicians and Surgeons of Ontario, Quality Assurance. Past work has included 10 years at the London Intercommunity Health Centre, 10 years at the Salvation Army Medical Clinic located within a homeless shelter and detox facility, 10 years at Regional Mental Health Care London, 5 years at London Middlesex Children's Aid Society and Genes Detention Centre for Youth, medical consultant to the London Drug Treatment Court. He also has Western University appointments including family medicine, psychiatry, and dentistry as a lecturer in opiate pharmacology. Please take it away, Dr. Lee.
Well, thank you, Louisa, and thank you for coming to this session on Sublicate. I am going to go through my disclosure slides here. Disclosures, our RAAM Clinic did receive funding from PHI back in 2014, 15, 16 as part of the Arctic PHI project. Presenter disclosures include honoraria from Indivior and Knight, and also OTN eConsult and consulting for the CPSO. Pharma has no influence in the content of this information. So what I'm going to talk about is the first few 75 patients that we've treated with Sublicate at the London RAAM Clinic. Just to give some background, to date, we have treated about 140 patients with Sublicate since it became available to us in October 2019. We first started using Sublicate as part of the Health Canada Special Access Program before it was commercially available, and then once it was commercially available, the use of Sublicate did not take off until after government coverage through the Ontario Drug Benefits Program or through NIHB. And so basically, we did put together a study of our experience with the first 75 patients. And just by way of background, this is the way Sublicate is supposed to be used, as you all know. There's 2 loading doses of Sublicate for a patient who is already on buprenorphine. The first 2 loading doses are 300 milligrams, and these are given 28 days apart. And then maintenance doses are 100 milligrams every 28 days, with a dosing interval of between 26 and 42 days. And so we accumulated data for the first 15 months of the first 75 patients, and this is the poster. You won't be able to see the details of this poster. This was presented in June 2021 at the CPTE conference, and it summarizes our experience with the first 75 patients. And I will highlight lessons learned, tips and tricks, and some of the pitfalls of using Sublicate in the early days. And so, as I mentioned, we started using this in October 2019. I think we had about 10 patients on Sublicate before it was commercially available in Canada in February 2020. But really, it stayed at about 10 patients until May, and that's when the usage dramatically increased when it was covered by government drug plans and NIHB. So with the first 75 patients, many of these patients were patients already stable on buprenorphine and wanted the option of not taking a medication daily. Here's the demographic breakdown of the first 75 patients. 60% were male. The average age was 39. And of this group, 44% were fentanyl users, and 36% of this group of 75 patients have had previous overdoses. And so our treatment retention, and this is the 1-year treatment retention based on some statistics and Kaplan-Meier curves and a whole lot of things that I don't understand. We analyzed our data at 15 months, analyzing at December 2020, at the end of December 2020, and again at the end of June 2021. So we have data from 15 months and 21-month data. And what we found was at 15 months, 60% of the patients, of the original 75 patients, were still on Sublingual for at least 12 months. Some of these patients were not on Sublingual for the whole 12 months because we analyzed, people were able to come into the cohort analysis at any time during treatment. So we had to do some statistical work to figure out that the 1-year retention rate was about 60%. Reanalyzing it in December 2020, and these stats are pending. That is something to come, but we do have some interesting information on that coming shortly at CSAM. And the reason for that is some patients who dropped out early after receiving only 1 or 2 injections later on returned to request to be restarted on Sublingual later on. So my initial feeling, my initial estimate on this is that our treatment retention probably is a little bit better at 21 months as opposed to the 15 months stats. What we learned was that dropouts from Sublingual, and this is dropping out for any reason, dropping out, lost to follow-up, returning to oral buprenorphine, switching to methadone, or going back to using their original opiate of choice. 50% of the dropouts occurred after receiving only 1 or 2 injections. And later on, we found that many of these people actually chose to come back to the program after a period of being away. So the median retention time in our cohort of 75 is 379 days. And interestingly, only 40% were able to receive all injections on time, meaning within the 28 days were recommended, but within 42 days, which is 2 weeks late, only 40% were able to receive all their injections on time. The treatment retention, we always want to compare fentanyl versus non-fentanyl users. Within fentanyl users, the treatment retention rate was about 75%. And in non-fentanyl users, it was around 70%. So this was statistically non-significant. So we found that there was no difference whether the patient was a fentanyl user or a non-fentanyl user. And this is the Kaplan-Meier curve showing the 2 groups. The 2 groups are almost identical out at the 1-year mark. As of August 21, we've had 138 patients we've treated. The first cohort of 75 patients included some very stable patients on buprenorphine, so you would expect that these patients would do a little bit better than the second cohort. The subsequent cohort were mostly fentanyl and hydromorphone users, because in the first cohort you would have treated all those very, very stable patients on oral buprenorphine. The next cohort, which will be interesting to analyze, is how do we do now for de novo patients coming to OAT on buprenorphine and comparing fentanyl, hydromorphone users, and users of other opiates. I think now we're up to about 145 by mid-September. By the end of August, we've treated 138 patients, and very happy to share our experience with that. So some of the issues that have arisen over this past 2 years, we find that there was more injection site pain with a larger volume, with the 300 milligram volume, and that volume is 1.5 cc's by sub-Q injection. There's less pain with the smaller 100 milligram volume, which is 1/3 of the volume. And we learned there was less pain with ice, applying ice to the injection area pre and post injection. Injection site pain also seemed to be better if you took the time to fully warm the supplicate to room temperature. There is actually an easier injection because it's less viscous when it's warmed up. It's easier to push the injection. It's easier to give the injection faster. Initially, when we first started, we were giving the injections very slowly as recommended by the manufacturer, but we found that it really made no difference whether you're injected fast or slow as to how it works. And most patients that we have like the injection to be given faster. Very few liked the slow injection. So again, warming the solution before injection and then icing the area and giving it quickly seemed to work better. We all have these very, very thin patients. Typically, patients are using stimulants, and it's very difficult to, in a laying position, to get enough sub-Q tissue to inject. So you get around this by injecting in the sitting position. So all of us, when we sit up, we have a little bit more subcutaneous tissue to grab. And if the volume is too large in a thin patient, meaning in a very thin patient, when you do an injection, you get a very large blob under the skin, which can be noticeable. Basically, you can keep the needle within the skin and inject it in multiple directions, sort of almost like in a star-like fashion, maybe in 2 or 3 injections without exiting the skin. And this helps us with those very, very thin patients where you can't find enough subcutaneous tissue to inject in. We have not tried alternate injection locations other than the recommended sites on the abdomen. Injection site reactions that we've seen infection, we've seen injections that are too superficial, multiple nodules, meaning the depot is in several different pieces under the skin, and sometimes mobile nodules. Sometimes the nodules get loose, and patients can actually move them around under the skin. The multiple nodules in a very thin patient is an intentional thing, but sometimes you do get multiple nodules even when you don't try to get multiple injection sites. So here's an example of an infection. This was a 300 milligram dose in a patient who's using fentanyl, and there's the reaction. And closer up, this is the IND that was done after treatment with antibiotics and an IND, and this is about 1 week post IND. So the IND is the larger site on the left, and if I just back up one and show you this lower site, that little black nodule you see there on the skin, that's where the patient tried to do his own IND. And so this is 1 week out after Keflex 500 QID this was at the 7-day mark, and it looks pretty good. We just continued on with Sublingual with the next injection on the opposite side of the abdomen. Everything seemed to be okay. There was no issues with this. Occasionally, you can give an injection that's too superficial, and so the bandage there is the injection that was given that day, the day this picture was taken. But the lower left showed an area where an injection was given too superficially, so almost probably intracutaneously, almost like a TB skin test. And what happened there was a bleb that formed in that area, but the patient didn't feel any withdrawal symptoms through the period of time, and it seemed to make no difference in his level of comfort or cravings to use fentanyl. But this is what happens when you inject it too superficially. He didn't tell us about this until it was time for the next injection. And it did go down in it took about a week for the blood to go down. And he's left with a little bit of a discolored area where the injection was given too shallow. Late supplicate doses, you do have to come up with a strategy for dealing with that, as only 40% of patients will have received all doses on time. That is before day 42, before day 43. It didn't seem to affect your retention rate, whether there were late doses or doses were on time. So 60% of patients always would have had a late dose at some time in their treatment course. So the way we deal with late supplicate doses beyond 6 weeks is considered late. We've always had the concern, have the buprenorphine levels dropped too low, and patients have used opiates again. Particularly, we were concerned about fentanyl. That is, if there was fentanyl on board and we gave a large dose of buprenorphine injection, supplicate, and it would precipitate withdrawal. And so what we did was we would give a test dose of 8 milligrams of buprenorphine in clinic, and if there was no problem, we would go ahead and give the supplicate dose as scheduled, as the dose as planned. If they were on 100 milligrams, we'd give them 100. If they're on 300 milligrams, we'd give them 300. And we've done this as late as 12 weeks. There's always this debate of 100 versus 300 milligram maintenance doses. And in our cohort, we showed that these patients were two groups. They were the chronic pain patients who required the larger dose, or fentanyl users would typically require the 300 milligram dose, but not all fentanyl users. But I would say maybe 60–70% of the fentanyl users would require the higher 300 milligram maintenance dose. What we saw with the first two loading doses, buprenorphine levels would typically drop after that first 300 milligram loading dose, and some of the data from the manufacturer shows that the buprenorphine levels drop below 2 nanograms per ml at day 21 after supplicate number 1, after the first 300 milligram dose. Initially, what we did was supplemented with oral for that week before giving supplicate number 2. But with time, we've learned that you can just go ahead and give supplicate number 2 at the 21-day mark. Occasionally, you could see patients who get these withdrawal symptoms after day 14, and in Timmins, they've used supplicate number 2 at day 14. I have not done that myself, but I have no concerns with giving supplicate number 2 at day 21 as opposed to waiting to day 28. One thing we've come across just in these past year is that we'll have patients who are on supplicate and they're doing just fine, and they will use the fentanyl every once in a while, and then they'll start reporting to you that maybe the supplicate does not seem to be covering all their withdrawal symptoms, and their UDS testing is showing that there's actually atizolam in their system. And so what we learned is that perhaps some of these withdrawal symptoms people are describing from fentanyl are actually atizolam or benzodiazepine withdrawal symptoms. And we cover this with diazepam 10 milligrams a day for 3 days is all that we've seemed to have required. And then that looks after those benzo withdrawal symptoms. And it's not really due to low buprenorphine levels. That we've learned with experience. We're doing more of this now, because as you know, most of the fentanyl supply that we have in Ontario is contaminated with atizolam. Giving early 100 milligram injections, this is the situation where patients who are on the 100 milligram maintenance dose and report ongoing withdrawal symptoms not due to atizolam, when you figure that it's not atizolam. Basically, we would just give the next injection, the next 100 milligram injection early, and then plan to give the next dose following this as a 300 milligram at day 28 after you've given the early 100 milligram supplicate injection. planned surgery. We've had patients undergo cholecystectomy and even simple procedures like IUD exchanges. We try to plan, if the surgery is planned, we try to plan for surgery when plasma buprenorphine levels are lower. So not early after an injection, and time the injection so that time your dosing so the planned surgery occurs after day 28 or after day 35 or close to day 42. Then go ahead and have the surgery, use whatever post-op analgesia is required, look at regional techniques, neuroleptic anesthesia, and then restart the buprenorphine Sublingual injections after recovery. This is data from the company showing buprenorphine levels. And if you look under the Sublingual columns over on the right side, it gives you some of the plasma levels, the min, the max, and the average. And if you look at the 300 milligram injection, the first injection, it shows the mean plasma level you're going to get after the first injection is 2.19. There's a peak of 5.37, which occurs in the first 24 hours, and it gradually goes to a minimum of 1.42. So this is why you get those withdrawal symptoms after Sublingual 300 number 1. It's because the levels are dropping down to 1.42, probably at about day 21. The 5.37 Cmax of a 300 milligram injection, for some of those patients who are only on buprenorphine 8 milligrams, 10 milligrams, they may feel a little bit sedated after that first dose of Sublingual 300 load. And you do need to warn them about that. There's many reasons for that. You know, they're on a low dose of buprenorphine 8 milligrams, or they have a dose of 8 milligrams buprenorphine, but they're not taking it properly, or it's not all getting absorbed. This does not happen after the second dose of Sublingual. This is more of a first dose effect. And this is more data from the company showing the effects of different dosing ranges of Sublingual. There's a 50, there's 100, 200, and 300. So what we have available in Canada is the 100 milligram and 300 milligram dosing options. And you can see the different levels. The dotted line shows the 70% mu-opiate receptor occupancy cutoff. Yeah, as mentioned, planned surgery, and you plan for surgery before the next dose is due. We did notice this effect reported by our fentanyl users, a euphoric blockade effect. So patients who were using fentanyl reported very little euphoric effect, reporting just sedation. And sedation could be due to fentanyl sedation versus itizolam sedation. So this is a very interesting effect that we've noticed amongst our patients on Sublingual who continue to use fentanyl. And in terms of our overdose data, we had one patient who had on Sublingual of the 75 had a non-fatal overdose, but used a very large amount of fentanyl, 10 points at a time, trying to get high. And this was reversed with a single dose of naloxone. So in my opinion, I think there's a safety signal to using Sublingual. There are no deaths due to opiate overdose or toxicity. Of course, you can't prove anything with data like this. There's no direct data to prove this. And we don't have direct data on patients, those lost to follow-up. More to follow on that, because some of these patients lost to follow-up did return to specifically request to be restarted on Sublingual. I think this was discussed at a previous session, fast Sublingual starts. This is what we started doing about 6 months ago. Fast Sublingual starts. What we typically do with starting people, this is a de novo patient that comes to the RAAM Clinic, we usually proceed with a home induction, and we give them 8 tablets of buprenorphine 2 milligrams. These are patients presenting to RAAM Clinic in no withdrawal, and they can decide when they're going to start this. We teach them how much withdrawal you need to be in before you start buprenorphine, and then they start it on their own. They take 2 milligrams and take it every hour until they've taken all 8 tabs, come back to clinic the next day. We've increased them to 20 and then 24, and then subsequently giving them Sublicate 300 milligrams. So that's what we did about 3 months ago, speeded things up. The product monograph for Sublicate will indicate to you that you have to be a patient. They want patients to be on a stable dose of buprenorphine for at least 7 days, 8 milligrams or higher before switching to Sublicate. But we have not found that you have to do that, and there's a certain urgency to starting patients quicker in these days of fentanyl. Well, or you can go faster Sublicate starts. Dr. Julie and Dr. Louisa in Timmins have a very, very fast protocol, a macrodosing protocol based on the California Bridge group, and basically give patients very large doses of buprenorphine, followed by Sublicate 300 milligrams done in hospital. Just to back it up a little bit, we have since modified our home induction protocol. These are for patients not in withdrawal. We will instruct them, we'll give them the 8 tablets. We'll instruct them to take their buprenorphine 2 milligrams every hour. If they do get precipitated withdrawal or feel very uncomfortable, we just tell them to take the rest of the tabs all at once now. So they may get 1 or 2 doses of 2 milligrams in, and then if things are not getting any better, then take the rest, and we'll see them in clinic the next day. And we will consider doing this protocol here, 20, 24, and then Sublicate 300, or we'll go with this protocol, speed it up really quick, and then give them the Sublicate 300 at that point in time. For patients on Sublicate requesting a taper from OAT, basically, if you look at the data, the decay curves of buprenorphine levels, you can just give them a single dose of Sublicate, take their last dose of Sublicate and just wait, and it will take about 4 or 5 months before the buprenorphine levels drop below 2 nanograms per ml. And at that point in time, if things are going well, they can just allow it to self-taper. We've also had patients come in on oral buprenorphine requesting to be tapered, and there was a paper out of the US that showed a group of patients where they just gave a single dose of Sublicate 100 milligrams as a terminal taper. And we've done this on 2 patients, patients on, I believe, buprenorphine 8 milligrams, both patients. We gave them a single dose of Sublicate 100 milligrams and just allowed it to self-taper, and they both did well. But tapering from Sublicate, basically just stop the Sublicate and follow. If no withdrawal symptoms onset and there's no relapse, then you're done. You've completed your taper. If things don't go well and there's a recurrence or a relapse to use, simply you can restart your OAT of choice, and if that is buprenorphine, then you can go back to Sublicate. So that's our experience with the first 75 patients. There's my email if people want to email questions to me. And at this point in time, I'm happy to take on some questions. Just looking at the chat, which I've just looked at right now. A question here, and it says, do patients have to be on 8 milligrams Suboxone to receive 100 milligrams Sublicate as an OAT taper? I don't have a specific answer to that question, but both of the patients where I did the terminal taper were on 8 milligrams of buprenorphine.
There were some questions about allergic reactions. Did anybody have any significant allergic reactions in your first 75 patients?
So we didn't have any allergic reactions in our first 75 patients. The only bad reactions that we had were probably things that we caused ourselves, giving an injection too superficial. We've not had any allergic reactions to Sublicate. We've had some reactions for patients on buprenorphine where they get the swelling, the peripheral edema in their legs. And those patients, we have not converted any of those patients to Sublicate.
Okay. And another question was, do you recall out of the 75, how many actually got site reactions, infection site reactions?
We've had 2 patients with 2 patients have treated with antibiotics with reactions, and 1 of them required an IND. And so, excuse the motorcycles again. So the 1 patient who got a site reaction, he was actually, sorry about that. He actually probably caused it himself because he was poking at it, playing with it, bumped it. And that was the 1 patient that had that little hole in his abdomen, and I think he might have tried to poke at it. That was the 1 reaction. The other reaction happened for unknown reason, contamination, infection for some other reason. So only 2 patients.
Yeah, and you know, yeah, and out of the now, Ken, the only reaction we had too was a patient, a site infection, was they tried to pick it out themselves, and it caused an infection at the site. Sort of the same idea of what happened with your patient. Another question was regarding surgery. Just wondering, does the timing of the injection relative to surgery, do you think it really matters? I guess with reference to post-op analgesia, and that sort of thing.
I think it matters a little bit because with any injection, you get a peak in the first 24 hours, and the levels stay a little bit higher for the first few days, and then level off. It's more of a concern early in using Sublingual in the first 4 months, say, before you've achieved steady state. Less of a problem after you've achieved steady state. So we did have 1 patient who had a difficult surgery. Basically, it was an IUD exchange. It seemed to be very, very painful, but she had her IUD exchange the next day after getting a Sublingual injection. And so in retrospect, I think we should have delayed the Sublingual injection until the IUD exchange was done, and then given the Sublingual 1 week later. So I think early on it might make a difference, and maybe day 1 it might make a difference, but beyond that, I don't think it makes that much of a difference.
And there's another question here, Ken. It's a bit of a loaded one, so give me a second to sort it out here. Did any of your cohort patients that were stable on 32 milligrams, so that stable on 32 milligrams sublingual, how was their experience? So in other words, when they received the Sublingual, did they have the same experience as being stable on 32 milligrams? And if so, and if not, did they require top-up?
So it's an interesting scenario. So the scenario that we had was there was a patient referred to us for Sublingual from a chronic pain physician on 48 milligrams of buprenorphine. I thought that seemed to be high, and the pharmacokinetic studies, that I looked at, would tell me that 48 milligrams made no difference compared to 32 milligrams. So we actually tapered this person down to 32 milligrams, and then further tapered them down to 24 milligrams. But at 24 milligrams, they were experiencing a recurrence of their chronic pain. I think it was back pain, something like a chronic pain condition. And so we bumped this person back up to 32 milligrams, and then converted to Sublingual 300 milligrams and kept them at 300 milligrams, and they did fine. So I think I have 1 patient who's on Sublingual 300 milligrams who requires a supplement of 4 milligrams a day. But that's the only 1 out of the 140 that we've treated. I see a question from Karina Chung about home inductions and doing it as an outpatient would be helpful. Yeah, home inductions are all outpatient, right? We give them 8 tablets. And if I was in Timmins, I'd be giving them more than 8 tablets. So I have 6 packs and 8 packs of buprenorphine of 2 milligram tabs to give to people in clinic. So a 6-pack or an 8-pack. I haven't gone between an 8-pack. So 16 is the most I've sent people home with to do a home induction.
How often do you follow patients after their first injection? And when do you see them in clinic? And did it change anything in terms of retention or continuous drug use?
After Sublingual 1, we typically are now booking our first follow-up at day 21. But they're welcome to call and come in sooner if they're experiencing any withdrawal symptoms or they're uncomfortable in any way. Have not had anybody come back at the day 14 mark. They come back at the day 21 mark, and maybe half of those patients will go on to get their second loading dose at day 21. And typically these are all fentanyl users. And so I think nowadays, I think what we're planning is, what I think is the way to go is supplicate number 2, 300 milligrams at day 21. I think I'll do that routinely for fentanyl users, because I think most of them will need that second dose earlier. And the fentanyl users uniformly report that the supplicate is blocking out their fentanyl euphoria. And this is an important thing that we've learned as well. When you're blocking out the euphoria, you're blocking out the euphoria for a long time. And so a lot of those dropouts that we see after 1 or 2, we mitigate that now by explaining to them that, after you get Sublingual, your highs are going to be blocked out for quite a while. And if you really, really want to stop using fentanyl, this is the way to go. But if you plan to continue using fentanyl, you're not ready to quit using fentanyl, then maybe you should stay on oral OAT before going on to an injectable, because an injectable, there's no coming back. And perhaps that's one of the reasons that one patient was picking at his injection site to get rid of the Sublingual depot so they can experience a fentanyl high. I don't know. That's pure speculation. But we have learned that it's very important to choose your patients, educate your patients very, very carefully at the beginning before you give your first Sublingual shot that, hey, we're blocking out euphoria. I can't promise you overdose protection, but if you don't get high, you might not die. So euphoric blockade may be a proxy measure for overdose protection.
And that's similar to the experience we have in Timmins also, Ken, is we find that the patients who want euphoria drop out, but interestingly enough, many of them come back.
Exactly the same experience in London.
Yeah, they come back. Yeah, it's fascinating.
About half the people apparently lost the follow-up from the RAAM Clinic after Sublingual. About half of them come back saying, maybe life wasn't so bad on Sublingual. They had a taste of sobriety for a couple months, and maybe that wasn't so bad. But maybe you had to go back out there and learn that lesson, and then come back.
Another question here, Ken, is: have you treated any elderly patients?
Let's see. The oldest patient we have on Sublingual is one chronic pain patient who I believe is 69 years old. That would be the oldest patient. The next oldest patient would be about 68, also a chronic pain patient, and then the next one would be about 60. But the great majority are probably in their late 30s, early 40s, between 35 and 45. So depends what you want to define as elderly. There really should be no difference in, if they can tolerate oral, they should be able to tolerate a depot injection.
It says here, you said you'd be willing to do 1 to 2 starts like Timmins. Would you do that as an outpatient?
Yeah, I would do that. I would do that as the scenario I could envision would be something I've given an 8-pack of buprenorphine to 16 milligrams. They go home. They've taken their 16 milligrams. They come see me the next day in RAAM Clinic. I'll give them another 16 milligrams, see how they do, and then fire a dose of Sublingual 300 of them. Yeah, I'll find the right patient for that. I will eventually do that when I get back from PEI.
For sure. And you're not with the biker gangs?
No, but I think I was on the ferry with some biker gangs the other day.
Have you ever seen patients metabolizing Sublingual sooner than the 26-day point, so withdrawal symptoms during maintenance dose, and so advancing the dose interval? So I'm guessing this question is once they're stabilized, they're on their maybe 3rd injection, 4th injection. Do you still find some people are metabolizing quickly, like we do sometimes with people who take methadone?
The only situation where you see that I've seen that is patient who reached steady state. They're on 300, then 100 maintenance. They're 4 to 6 months out. Let's say they're 6 months out on Sublingual 100 milligrams. And then for whatever reason, they feel some cravings and withdrawal. then I will give them the next dose early and then switch to the 300 milligram maintenance. I have not seen the situation where someone who's on a steady 300 milligram maintenance complain of ongoing withdrawal symptoms from opiates anyways. We've sort of teased it out, like we thought a lot of these patients, what's going on here, we don't understand, but we seem to have teased it out that we think it's due to using fentanyl and experience etizolone withdrawal, a benzo withdrawal. So we've treated those patients with diazepam 10 milligrams for 3 days, and it seemed to make the symptoms go away. But I've not seen patients on steady state 300 milligram maintenance suddenly metabolize early and go on to require shorter dosing intervals. And so those stable patients on 300, we've maintained its dosing interval at day 28. We've not had to go shorter. And that goes to the whole 140 patients, not just the 75.
Right. And I guess that we'll go back to what you said is if some patients are still using fentanyl at the 6-month mark and they start experiencing, and then they cut back at the 6-month mark and they're experiencing withdrawals, like you said, it could be benzo withdrawal more than anything if they've still been actively using. If there if coverage is an issue, who would you definitely start on sublingual buprenorphine versus Sublicate? It seems Sublicate is so much more convenient for patients.
So all our patients who are on oral OAT with buprenorphine, we discussed the option of whether it's the probuphine implant if they're on a lower dose, or the option of a monthly injection. So basically, it's patient choice whether they want to continue oral or switch to a depot. It's always dependent on coverage, because oral is cheaper than the $600 it costs for a Sublicate injection, right? So, a lot of people, if they have to self-pay, can come up with the $15 or $20 a day, but you can't come up with $600 all at once. So it's really a patient-driven issue. It's an economic issue if there's no coverage, and that's sort of beyond the control of us docs.
Yeah, and there's no, at this point, compassionate coverage. At this point, we've tried to apply for compassionate coverage for some of our patients, and they just don't qualify. We've tried.
It's not been available.
Yeah, for sure. Yeah. When you have packs to send home for home starts, do you dispense them yourself from the RAAM, or do they go to the pharmacy? What does the pack look like? I know this is a Sublicate talk, but always interested in how people are managing home starts.
So what I have in clinic is a stock supply of buprenorphine 2 milligram tabs. I may in the future start a stock supply of 8 milligram tabs based on what you guys are doing in Timmins. But right now I have a stock supply of 2 milligram tabs. And what happens is that we have our stock supply, we dispense, the pharmacy, we get it from the pharmacy in blister packs. So that's why they're packs, they're not in the bottle. And what we do is we dispense it from our clinic and send this prescription to the pharmacy who supplies our buprenorphine, and they bill that to the patient if they have ODB coverage, NIHB coverage, or private insurance coverage. It's billed, and if there's no coverage at all, then we just eat the cost of the buprenorphine 2 milligram tabs. Or sometimes the pharmacy will eat the cost on our behalf. So it's a little thing that we do.
That's why you have to have a really good relationship with your pharmacy that you choose to dispense to these patients. I find that's key, is having a good relationship with the pharmacy that's dispensing to your patients, for sure. I know just Jennifer asked this question. In Timmins, we actually carry similar in our hospital for our community withdrawal management. We do similar to what Ken's doing. We have some there. We send people home with them actually in little small vials. We do the same from the Emerge. We have Suboxone tabs in small vials. We send them home with, especially if it's after hours and the pharmacy is closed, because we don't have a 24-hour pharmacy in Timmins. We do send them, but same thing is that if patients can't afford it, we eat the cost of it if we need to. So. Is there any trial or data for Sublicate use in adolescents?
Let's see. No, I don't think there's any trial data. We have used it in adolescents. I think the youngest I've used Sublingual is, I think, 15. And I have a number of 16, 17-year-olds. So maybe there's about 5 of those patients in adolescents. In my mind, when you do the risk benefit analysis and you got the youngest fentanyl user I've had in clinic is 12 years old, right? That's really crazy. But kids will get into fentanyl in particular, very young, and you do your risk benefit calculation, and you go, I'm not that concerned about giving Sublingual to someone under the age of 18 if they're already using fentanyl. My Suboxone and Sublingual that I'm using is way less harmful than the fentanyl that they're using on the street. So I have no concerns in using clearly off-label. Using Sublingual or Suboxone is not even indicated under the age of 18 if you look at the monograph. I have no concerns with using both of those options in someone under the age of 18 if they're using fentanyl and doing something as dangerous as that.
Mm-hmm. Are you seeing better retention with Sublingual versus sublingual buprenorphine? And as an extension, any plan on comparing your Sublingual data to sublingual buprenorphine?
Funny that you should ask. Our next study that's coming out right now, which is going to be out at CSAM, which is going to show the retention data for this 75 cohort analysis. We have another study coming out that's comparing methadone versus buprenorphine versus Sublingual, and that's coming out in CSAM at the end of October. So just generally speaking, I think our retention rate on oral buprenorphine is probably about 40–50% at 1 year, whereas with Sublingual, it's about 60% at 1 year. Possibly a little bit better if we get a few returnees for the 1 or 2 after dropping out after 1 or 2 doses. So I think just like in the psychiatry literature, a long-acting injectable shows better treatment retention, treatment of schizophrenia than oral medication. So in this aspect, it's not surprising.
And I think going back to that question is retention too with the Sublingual injection. The nice thing is if someone has already received Sublingual and they come back within 12 weeks, all you need to do is give them a small test dose to ensure there's no precipitated withdrawal. You can just give them the Sublingual again that day. So you don't have to give them. So just their overall retention is you don't lose them to needing 7 days of Suboxone stabilized prior to Sublingual. So I think it's easy for people to come back into treatment if you're doing what you're doing. You've made it easy for them, right? It's very flexible. You give them a test dose, you can give them Sublingual 4 hours later, and they're back in treatment versus making them leave and restart for 7 days. So I think that's awesome for retention treatment.
Yeah, we describe that as our flexible dosing option.
I love it. I love it. Along with your flexible reentry approach.
Yeah, flexible reentry approach, flexible dosing approach.
Yeah. You mentioned giving dose number 2 at 21 days for fentanyl users. How would you proceed thereafter?
I would see them after the first 2 doses. I would see them at 28 days because they're usually fine after giving the first 2 doses. And at that point in time, you can decide, am I going to continue at 300 milligrams because they're still using lots of fentanyl, or they've reduced their fentanyl use substantially and I can try a 100 milligram dose. And again, if the 100 milligram dose doesn't work and they come back 2 weeks later, I would just fire another 100 milligram dose in, and then next time keep them at 300.
Great.
Again, a flexible dosing option.
Perfect. And any changes noticed in other substances used? So, often patients with opiate use disorder have polysubstance use disorder. So, cocaine, amphetamines, etc.
Well, we did collect UDS data as well. And the UDS data, we would test everyone's UDS because it was a cohort analysis study. We sent them all to the lab for chromatography just to see what was in their urine. And there was a non-significant trend to an overall decrease in substance use, but nothing significant. So we did show kind of like, kind of a little like this, but not huge. But the big bonus, I thought, was that none of the fentanyl users died. And so my endpoint goals are a little different than abstinence or substances in their urine. My endpoint goal is to basically, are you still alive after 1 year? And that's a win.
It's harm reduction, yes. And what's interesting that we're finding with a lot of our patients is there isn't a lot of big change, but the way they use drugs changes. So because they're not using IV fentanyl anymore, they're not using IV crystal meth. And that's what we found. Now they might be smoking crystal meth or smoking speed. They're still using those drugs, but from a harm reduction perspective, they're using them differently, which has been awesome. So we're hoping to capture that data. Although they're still using it, they're using it in a different way.
Yeah, that's exactly what we found in London as well. They're using it in a different way. They're still using, but they're using it in a safer way. But I didn't think of that when I was collecting the data at the beginning. So I don't have that data, but I think it's true.
You'll have to start collecting it, Ken, for your next study, the next study. How much do you think patient selection / fit ties into the difference in treatment retention rates?
Huge. Because, now, because we're educating, we know that it provides the euphoric blockade. We know that the patients going into Sublingual now know that we're blocking their fentanyl high. And so, yeah, we're getting a more motivated patient who wants to stop using fentanyl, because if you use fentanyl on Sublingual, you get nothing out of it. And so our retention rates will look good because we tell patients that, yeah, we're blocking out your high. So it's not totally a direct comparison, but it's a comparison compared to oral. It's better for that group of patients. And so how do you quantify that, right? So our retention data might look really, really good, but it's a different subset of patient who chooses methadone versus a patient who chooses safe supply, who chooses oral OAT with buprenorphine versus injectable OAT with Sublingual. They're all different patient populations and they're not entirely comparable.
Anything else you wanted to add, Dr. Lee?
I've been very impressed with our outcome with Sublingual. I think it's something that needs to be, strongly considered in these days of fentanyl, and especially now because of the toxicity of fentanyl and the street supply now. Maybe we should all be doing it quicker rather than slower, right? So when we're doing conversions, so let's say you either do your conversions really, really slow by microdosing, and these are your methadone conversions or patients on stable oral opiates, or you do it really fast. It's that in between. The in between is uncomfortable. So you either go really slow or you go really fast, and then discuss Sublingual at some point in time, whether it's sooner or later.
Yep, and I think we're seeing the same thing, is that there's a trend now where people are coming in asking for Sublingual because it's much easier for their quality of life. I find now that's what's happening, is people are coming in saying, I need to get back to work. My kids are coming back into my care, and so there's that patient also. So when we look at picking the patient for the perfect patient for Sublingual, I think those things factor in also.
Yeah, and we're finding the same thing in London. We're getting patients coming from safe supply, whether they're getting their own safe supply or someone else's safe supply, coming to request to go on, well, they call it the needle. They don't call it Sublingual. I just want to go on the needle.
Yeah, no, for sure. I think they're finding, it's interesting now, they're finding the providers. They're looking for the provider that can give them Sublingual. Right? It's interesting. Well, thank you so much for the very informative and very innovative session. Really appreciate it, Dr. Lee. Thank you again. And thanks everybody for attending.